Assalamu alaikum, everyone. Hope you're all doing well. Um, so today we're going to have this session on clinical anatomy and nerve injuries. So it's three lectures that I'm going to try and finish in an hour because I know everyone's really busy right now. And shorter sessions are for the best. Um, I'm not going to go over the stuff that you've taken in previous lectures. So brachial plexus, lumbosacral plexus, nerve functions, muscle functions. I will not go over that. I will just go over the injury aspects and everything else that's new to you. And I try to organize it in a way so you can easily understand um, all the different parts. Okay, so let's get into it. And before we do, if you have any doubts, you can call me on my number. I mean, text me, or you can email me. Okay, Bismillah. So this is the brachial plexus. You can pause the video and look at it if you need a review. So the first one is herb Duchenne palsy. Let me just get my pencil. So so the cases, each case is going to have a typical sign that tells you that this is what the question's trying to ask you. And for this one, it's going to be the weighted tip hand. And the reason it's called the weighted tip hand is because it looks like the waiter is trying to ask you for a tip behind your back or behind their back. So how does this herb Duchenne's palsy happen? It could be because of a direct fall on the shoulder or during childbirth due to forceful separation. So you see the angle between the neck and the body. I mean, between the neck and the shoulder, this angle over here. If this angle is excessively increased, it could cause damage to the brachial plexus, the upper part, and cause this. So if the patient would present with an adducted shoulder, meaning it would be uh, right next to the body. The elbow would be extended, the forearm would be pronated, and the arm would be medially rotated. Uh, this is what will happen. And then in terms of sensation, you will have a loss of sensation over the lateral aspect. And the reason for the adducted shoulder is because you're going to have a loss of abduction, and we will see why in the next slide. Extend the elbows due to flexion loss. The pointed forearm is due to supination loss, which is because the biceps are affected. The medially rotated arm is because of the lateral rotation loss, which is because of the supraspinatus, infraspinatus, and teres minor being affected. That is the rotator cuff muscles, obviously. And the loss of sensation is because of the cutaneous superficial nerves that are coming from this part of the brachial plexus. Okay. So the muscles affected are these: deltoid, supraspinatus, infraspinatus, teres minor, biceps, and brachialis. The nerves affected would be axillary, muscular, cutaneous, and suprascapular nerves. You don't even need to remember any of this. As long as you know the brachial plexus, you know what kind of nerves, which of the nerves come out from C5 and C6, and then which muscles are supplied by those nerves, right? And then if you know the function of the muscles, you can easily know that if the muscles don't work, what's going to happen. So this is how the patient would present. As you can see, medially rotated arm, pronated, waiter's tip appearance. That's the key word you should look out for in questions. Now we move to Klumpke's palsy, which is another brachial plexus defect. And this is a lower brachial plexus defect, so it's C7 to C8, and the typical sign here is a claw hand. Previously, it was a waiter's tip. Now it's called claw hand. And here are some real pictures of what it would look like. So the reasoning could be, again, it could be during childbirth, but instead of an increase in the angle, if the baby's upper limb is pulled during delivery and there's excess stretching of the arm, it could lead to damage of the lower brachial plexus. But in the previous case, it was an increase in the angle between the shoulder and the neck, right? That caused herb Duchenne's palsy. Or holding onto something like a branch when you're trying to not fall could also cause this because of Hyperextension, not hyperabduction. I'm sorry. It should say hyperextension over here. Okay, so how we could present is the flexors of the wrist and the finger and the intrinsic hand muscles will be paralyzed, which is why you see this kind of appearance. And this is obviously because of the nerves. Ulnar and median nerves are affected because those are the nerves that come out from C7, C8. Or a major portion of them comes out from this section of the brachial plexus. You will also have a loss of sensation along the medial border of the forearm and hand, again because of the superficial nerves that come from the superficial branches of the median and ulnar nerve. So medial border of the forearm and hand is where you would have loss of sensation. And it may be accompanied with Horner syndrome. And the reason for this is Horner syndrome is basically it's something that happens if you have damage to the sympathetic trunk. The sympathetic trunk starts at T1, which is in close proximity to C8. And this is why you could have Horner syndrome. So what is Horner syndrome? You're going to have these two main symptoms, which you should remember. Ptosis, which is a drooping eyelid, meiosis, which is a constricted pupil, and anhidrosis, which is loss of sweating on the face. This is all going to be happening on the side where the sympathetic trunk is affected. And again, the sympathetic trunk starts from T1, which is in close proximity to C8, which means it could be affected along with Klumpke's palsy. And that's why you would have Horner syndrome. It's sympathetic fibers. You don't need to know the ganglia. Just sympathetic fiber damage. So for Klumpke's, you're going to have the flexors of the wrist and finger affected and the intrinsic hand muscles, such as the thenar and hypothenar. And the nerves affected are ulnar nerve and the median nerve. So now you're going to have injury to the long thoracic nerve, one of the most important cases, pretty much guaranteed to come in the exam. The muscle involved would be serratus anterior muscle, which is this muscle over here. And the typical sign, which would be given in the question, is the winging of the scapula, which is this right here. It's basically called winging because it looks like this person has a ring. And it happens when the medial border, which is this border of the scapula, moves laterally, or the scapula is usually sitting on the thoracic wall. If it moves posteriorly and like bulges out like this, that could cause wrinkling of the scapula. It's more pronounced when the patient's asked to push against the wall, like he's doing in this picture. And the nerve involved is obviously long thoracic. So the long thoracic nerve is actually an exception as it runs on top of the muscle, as you can see here. It's running on the surface. So if a person is stabbed in somewhere along the rib cage, or they're shot there, or they have any kind of like bad trauma in this region, it could lead to damage of the long thoracic nerve. Another scenario is mastectomy. If you're doing a radical mastectomy, which is removal of the breast tissue in females, it could also lead to a long thoracic nerve injury if you're not careful, because it runs along the path. So the other presentations which you would see other than the winging of the scapula are the upper limb will not be able to elevate over the horizontal position. That's because serratus anterior is responsible for this function. So basically just remember as the serratus anterior would not be able to perform this function. Injury to suprascapular nerve, okay. This is a smaller nerve, not as important, but still should cover it. The muscles involved are the supraspinatus and infraspinatus, obviously, because that's what's supplied by the suprascapular nerve. Usually the damage occurs in the suprascap in this notch, which is known as the suprascapular notch. And here is a better picture. The suprascapular notch here is where this nerve could be impinged or it could be damaged. It could also be damaged in this sphenoglenoid notch, but that's not really too important. So I wouldn't focus on it if I was you. So you would present with the following things: difficulty initiating abduction. Abduction means moving the arm away from the midline, and that's because obviously the rotator cuff muscles, such as supraspinatus and infraspinatus, are responsible for this. So if you lose them, you're going to lose this function. And you would have a weakness in lateral rotation, which is lateral rotation of the arm, which is outwards rotation of the arm. So this is what would happen in suprascapular. Now we move to subscapular. Again, not that important, but we'll still cover it. So the muscles involved, as it suggests, subscapularis and teres major. Again, if you know which nerves supply which muscle, you're basically done with this lecture. You can just like put it on 2-speed and you'll be done with it soon. So there really isn't a typical sign, unlike the other ones, and the presentation is weakness in pronation of the arm. Okay, and pronation of the arm is median rotation of the arm. So that's what the subscapularis does and the teres major. So yeah, just like what function the muscle performs, just imagine that it doesn't. That's what will happen. Now we have injury to the thoracodorsal nerve. So this nerve is in the, it's like present, uh, it supplies one of the back muscles called the latissimus dorsi. And latissimus dorsi is a very large muscle. It doesn't really have a typical sign, but the nerve passes inferiorly along the posterior axillary wall. So as you can see, the axilla would be somewhere over here, right? And it's passing right along the posterior surface of the posterior wall of the axilla. So any surgery that is really that involves the axilla can cause damage to this nerve. And examples of such surgeries, again, mastectomy. Again, the other nerve mastectomy can damage is long thoracic nerve. It causes weakening of the scapula, or it could be scapular lymph node excision, which obviously you do in any kind of like malignant case. So any of these surgeries could damage the thoracodorsal nerve, which supplies the latissimus dorsi. So what would you see? The opposite function of the latissimus dorsi, which is adduction. You have problems in adduction. The latissimus dorsi is the main muscle for adduction, right? And you would also have problems in extension and rotation of the arm. Again, just reverse the function and you'll be good. Now we go to the musculocutaneous nerve, which is one of the peripheral nerves. So the muscles involved will be the flexors of the forearm, the biceps, the brachialis, and the coracobrachialis. Muscle, which is a flexor of the forearm called brachiodialis, but it's not supplied by musculocutaneous. It's supplied by the radial nerve, so it would not be affected in this case. But the rest of the flexors would be affected. There isn't a typical sign. And also the musculocutaneous has cutaneous nerve of the forearm. And as suggested, the lateral cutaneous nerve of the forearm supplies the lateral forearm, quite simple, really. And the injury to the musculocutaneous could be due to a stab wound or a lateral cord lesion because it comes from the lateral cord, the brachial plexus. And how would it present like? It would present with the weakening of elbow flexion, obviously, because the flexors of the arm are affected, right? But the flexion isn't completely lost because brachiodialis is still present, which is supplied by radial nerve. So even if musculocutaneous is affected and these three muscles are lost, brachiodialis is going to save the day, and preserve some semblance of elbow flexion. You're going to have weakening of form supination. Again, not complete because the supinating muscle, which is the main supination muscle in the body, is going to prevent complete loss, but the biceps are lost, which causes weakening. And then anesthesia over lateral aspect of the forearm because of lateral cutaneous nerve. So I hope that's clear. Now we have injury to the axillary nerve, and this is the muscles involved would be the deltoid, the teres minor, but really you need to focus on the deltoid. So the typical sign is going to be around the shoulder, and this photo, unfortunately, it's been cropped. Let me try and fix it. Let's see. Let's try and. Ooh. Um, okay. So you can't really see it, but I'll draw it for you, so don't worry. So basically, what would happen is when you have a shoulder, usually you're gonna have some sort of like contour to the shoulder, which means it's gonna have some definition of the bones. It's gonna be like, you know, I'm not a good. You see some kind of definition. You see the muscles. But what would happen if you have deltoid injury or if you have deltoid atrophy due to axillary nerve injury, because the axillary nerve supply the deltoid, is it would look something like this. You see what I mean? You would see like the shoulder would be rounded, and there would be loss of definition. You wouldn't be able to see any muscular definition or any bones. It's very obvious. I'm sorry that I don't have a picture for it. I did, but it's been cropped out not very nicely. I apologize for that. The axillary nerve, uh, it passes inferiorly to the humeral head. It passes inferior to the humeral head, right? So basically, when it basically circumflexes around the humeral head, around the surgical neck of the humerus, more specifically. And then because of that, if you have any damage to the surgical neck of the humerus, the axillary nerve could be damaged. And if axillary nerve is damaged, you're going to have deltoid atrophy. Okay. You're also going to have loss of sensation over the lateral aspect of the proximal arm. Again, this is lateral aspect of the proximal arm, not of the forearm, which is what was the case for the median nerve. You need to be really careful with what they tell you in the questions because they're going to try and catch you out on the small details. So proximal arm, not forearm. And the reason for this is because we have a nerve called the superior lateral cutaneous nerve, which is a branch of the axillary nerve that supplies the proximal arm. So it's going to be basically right below the acromion. You're going to have on the arm a loss of sensation if you have axillary nerve damage. And obviously, the loss of function would be you can't abduct your arm because the axillary nerve is supplies the deltoid, and the deltoid main function is abduction. That's very obvious. You can see here, this is a surgical neck fracture. The fracture is over here, and because of this, you have axillary nerve injury. Now we have injury to radial, and the muscles affected would be the extensions of the forearm. Now, you might tell me, okay, but the radial nerve also supplies the extensions of the arm, and you are correct. It does supply the extensions of the arm, but the most common site for the radial nerve to be injured is in the spiral groove while it's running in the humerus, in the mid shaft. So at this point, it's already supplied most of the extensions of the arm, which are the muscles over here, and the next muscle that it will supply are the forearm extensors, and that's why the forearm extensors are affected. However, if the radial nerve was affected closer to its origin, somewhere near the axilla, then the extensors of the arm would also be affected, such as the triceps, stuff like that. Again, the typical sign, which should be given in questions, is wrist drop, which would look something like this. It's because the extensors of the arm don't work, so you can't extend your wrist. And that's why it's like floppy like this, just like downwards. You will have sensory loss on your posterior forearm and hand. I'm sure you've done the hand lecture, and you know the different types of the different spots of the hand that are innervated by the three peripheral nerves. So for median nerve, it would be this part on the dorsum of the hand, and then the palmar portion would be most of the palm, right? So that would be lost if you have injury to radial nerve. And another area other than the mid shaft, which is this, where the radial nerve can be injured, is the anatomical snuff box. Just 1 second, guys. Hey guys, Assalamu alaikum. I'm back. Sorry for that. So again, the radial nerve could be damaged other than this one, which is the spiral groove mid-shaft fracture. You could also damage it in the anatomical snuff box, which I'm sure you guys have taken in anatomy earlier.
At this point, the only part of the radial nerve that's left are the superficial branches. So really, if the damage at this point is not as severe as it was earlier, so in this case, you're only going to have slight anesthesia because it's a superficial branch versus cutaneous, and the anesthesia would be here. Oops, the anesthesia will be over here in this small circle. And the reason it's so small is because we have overlapping branches from the ulnar and the median nerve that make up for the loss of innervation by the radial. So that's it for the radial nerve. Wrist drop, remember that. That's the most important thing. Now we have, if you have injury to the median nerve, the muscles that will be affected are the flexors of the wrist and the digits, which is supplied by the median nerve. At least some of them are supplied by the median nerve, and the pronators will also be affected. The typical sign is the hand of Benedict, which would present like this. It's like a gun, but pointing upwards. And it's because of the loss of flexion of the lateral three digits. So the lateral three digits are these digits. When you put a person into anatomical position, these are the lateral three digits. And if a person is asked to flex, they'll be able to flex these two, but they won't be able to flex these. So you would have this kind of appearance. So the typical case is a supracondylar fracture, which is just above the condyles of the humerus. And the median nerve would be running through here, and then it would be damaged. And the so you would have some other presentations would be weakened wrist flexion, because obviously the flexors of the wrist are affected, and ulnar deviation upon flexion. So what does that mean? It means that when you flex, when you try, and if a person has a median nerve injury and they try and flex their wrist, the wrist would flex towards the ulnar direction, which means it would flex medially. Your wrist would go medially. And the reason for this is because we have, do you remember like the flexor muscles, flexor carpi radialis, flexor carpi ulnaris? So now obviously if the median nerve is injured, the flexor carpi radialis is not going to work because the median nerve innervates it. So the only flexor that's working is the flexor carpi ulnaris, and it's basically going to pull the wrist towards itself because it's unopposed by the radialis in this case. Hence, there would be ulnar deviation. You would have pronation loss because obviously the pronators are supplied by the median nerve. You'd have loss of thumb opposition. What does that mean? It basically means when you try and touch your thumb to your pointer finger, right? And the reason for this is because you would have the loss of the thenar muscles, and the thenar muscles are supplied by the median nerve. So if the median nerve is damaged, you're gonna have loss of thumb oppositions, of loss of basically any thumb function. You'd also have sensory loss over the hand in this pattern. So the median nerve is this pattern. As you can see, the green ones. So we have carpal tunnel syndrome. The nerve affected is the median nerve, and why? Is because we have this, we have all of these flexor tendons present here, and we have something called a flexor retinaculum, right? Or transverse carpal ligament is another name for it, surrounding it. And basically, sometimes we might have tendonitis of one of the tendons, or we might have fluid buildup, which causes compression of all of the tendons within this compartment, right? All of these tendons could be affected. And how you cure this is by making a split in the transverse carpal ligament or the flexor retinaculum, allowing for the pressure to be released. So if it's a severe case and if it's been going on for a long time, you would have thenar muscle atrophy because the median nerve supplies the thenars. Thumb opposition loss again because the thenars are responsible for all thumb functions, and then sensory loss over the hand in this pattern. Okay. And now we have one of our last things, or the second last thing actually, in this lecture, and then we're done with the first part. So we would have injury to the ulnar nerve, and it's because of the muscles involved would be the flexors of the wrist. Again, as I told you, some of them are supplied by the ulnar and some by median. You have the hypothenar muscles, which are the ones present like opposite to the thenar muscles. And then you have the interossei muscles, the palmar and the dorsal interossei muscles, which are present on your phalanges, right? So the typical sign would be claw hand. And where else do we see this? We saw this in the second case that we took, Klumpke's palsy. And it makes sense, right? Because Klumpke's palsy is C7, C8 damage, and all the nerve comes from there. So it makes sense that some of the things are overlapping. And it might look similar to Benedict's hand. This is the picture. And you might say, oh, well, this is Benedict's hand, but there's two differences, which are really important. The first one is that this person can oppose their thumb. They can bring their thumb to their pointer finger. And you remember in Benedict's hand, they can't do that because the thenar muscles are damaged. So the thumb is basically useless. And the second thing is the hand of Benedict happens when you ask the person to flex. But for this, it's at rest. So the patient presents to you like this. You don't ask them to flex, right? So those are the two main differences. And the main reason for this kind of injury is medial epicondyle fracture, as you can see in the X-ray over here, because the ulnar nerve runs under the medial epicondyle, actually. So the other presentation that you would see are weakened wrist flexion. And this time, instead of ulnar deviation, as you had in the previous one, you're going to have radial deviation because the ulnaris is affected this time, not the radialis. The radialis is intact, it's unopposed, so it's going to pull the wrist towards the radial region. You're going to have an inability to flex the distal interphalangeal joints because the ulnar nerve, but only for digits 4 and 5, which is this, right? These will be unable to flex. Only the digits, by the way. The distal ones. So like, you know, the ones that you click on the mouse, like, for example, imagine you're clicking on a mouse, you use the very distal joint only. You don't move your whole finger. So that joint is going to be affected in 4 and 5 because 4 and 5, the fourth and fifth deep tendons, the deep interphalangeal tendons are supplied by the flexure digitorum superficialis. Okay, so wait. You have this muscle called flexor digitorum superficialis. I don't know if you guys remember it. And this muscle has double innervation, or its tendons have double innervation. 1, 2, and 3 are supplied by the anterior interosseous nerve, which is a branch of the median nerve. And then 4 and 5, the fourth and fifth tendons, are supplied by the ulnar nerve, which are these two. So if you have an ulnar nerve damage, then 4 and 5 would be affected, but 1, 2, and 3 would be fine. So you have loss of flexion by distal interphalangeal joints if you have ulnar nerve damage. And the distal interphalangeal joints are the very, very distal joints, like the ones you use to press the mouse, right? These three would be fine because they're supplied by the anterior interosseous, also known as the median nerve. So you would have paralysis of the hypothenar, the interossei, and the lumbricals, the third and fourths. I mean, this is very like deep. If you remember thenar and interossei, it's fine because that's more than enough for you. And then you have sensory loss over the hand, and the pattern of sensory loss would be as seen here, right? You would have the digits 1.5 digits, which are the pinky finger and the ring finger, right? I forgot the scientific name, so I'm sorry, guys. And you can also have ulnar injury in the medial epicondyle, but another region is the hamate. So you know the hook of the hamate, the ulnar nerve goes under it. So if you have a hamate fracture, it could cause ulnar nerve damage. And what would happen is you would have only these two presentations. These are the only two things that would happen. This would not happen. And why? It's because if the injury is happening so distal, it's already supplied the flexors of the wrist and the forearm, and it's already supplied these branches to the distal interphalangeal joints of the flexor digitorum superficialis. So the only things that will be affected are the hand muscles, which are within, like the intricate hand muscles, and the sensory branches, which are the cutaneous branches. So that's what would happen if you have a distal injury of the ulnar, which is at the hamate. Okay, last thing for this lecture, and then we're done with this part of the lecture, and then you can have like this is recorded. Never mind. You can just pause if you want. So you can have 4 types of fractures. The first one is a surgical neck fracture. The nerve is the axillary nerve because it's circumflexing, it's coming from behind, as you can see here. And the artery is the posterior circumflex humeral artery. Now you also have an anterior circumflex humeral artery, but the posterior one is more likely to be damaged because it's larger. So that's what would happen if you have a surgical neck fracture. If you have a mid-shaft fracture, you're gonna have damage to the radial nerve because it's running in the spiral groove. You can see here, it's running in the spiral groove. And the artery would be the profunda brachii, which is a deep branch of, it's a deep origin of the brachial artery. If you have a supracondylar fracture, which is over here, as you can see, just above the condyles, the artery affected would be the median, or the nerve affected would be the median nerve because it's running here, like as you can see, over here. And the artery would be the brachial artery because the brachial artery runs just at this point, and this is the point where you take the pulse for the brachial artery also. The medial epicondylar fracture, we just did this, it would cause ulnar nerve damage because the ulnar nerve runs right under it, as you can see over here as well. And there's no artery associated with this kind of fracture. So that's it. Also, supracondylar fracture could be due to Fuchs. That's the most common cause of supracondylar fracture in children, especially because they have weaker bones and ligaments. And it's associated with Volkmann's ischemic contracture. We had this last year, but your slides did not have it. So you don't really need to know it. But if you want to search it up, you can search it up. It's something that happens with supracondylar fractures. So that's the end of upper limb nerve injuries. Now we're going to start with lower limb nerve injuries. It's much lighter. This is the lumbosacral plexus. You can pause it if you want to go over it. But this one is not as detailed as upper limb, so you should be good, inshallah. Okay, so you could have injury to the superior gluteal nerve, which is one of the main nerves that comes from the lumbosacral plexus, and it's the one that's over here. As you can see, it's going superiorly. And how can it be injured? Most of these nerves are injured the same way, a posterior hip dislocation. And the muscles would be the muscles that it supplies. Those are the ones that are involved, gluteus medius and minimus. And the characteristic sign you would see is the Trendelenburg sign. So what would happen is you would have hip drop on the contralateral side to the nerve injury. And contralateral means the opposite side. So as you can see here, if this part, which is this person's right, is affected, the hip drop would be on the left side, right? This is the left side. That's where you have hip drop. And the reason for this is because gluteus medius and minimus are hip abductors. So the hip abductors will not work. And this will not work on the affected side. That means if he's affected on the right, this side, then his hip abductors on the right won't work to stabilize his gait. So his gait is going to be unsteady and uneven, and you're going to have Trendelenburg gait with hip drop. So basically, think of it as someone like like a waddling duck, similar to like not similar to a waddling duck, but it's like their hips moving up and down. The waddling thing is its own gait. Forget about it. But like his hips or her hips would be moving up and down if they have injury to the superior gluteal nerve. The function loss would be hip abduction, obviously. Now we have inferior gluteal, just like we have superior gluteal. So this is the inferior gluteal nerve over here. And it can also be injured the same way because it's very close proximity to the superior gluteal, really. The muscle involved would be the gluteus maximus muscle. And how the person would present would be a problem climbing stairs or standing up from a seated position. And why is this? It's because the gluteus maximus is responsible for hip extension. And to climb stairs, you need to extend your hips. To stand from a seated position, you need to extend your hips. You can try it. Like right now, if you try and get up and like really try and notice what muscle you're using, you're going to see that you're using your gluteus maximus. So the function loss would be hip extension, and you would have a problem climbing stairs or standing up from a seated position. Now, if you have an injury to the femoral nerve, the most common scenario is during surgeries which repair hernias, right? You studied like different types of hernias, and there's a few associated with the femoral, like with the inguinal ligament, and all of that is in very close proximity to the femoral. So if they're being fixed, then the femoral nerve can be damaged. The muscles involved would be the ones that are supplied with the femoral, which is quadriceps and sartorius, right? The four muscles, the vastus muscles, and yeah. The function lost would be knee extension, is the job of the quadriceps, so that would be lost. You'd have a sensory deficit on the thigh and the medial leg and foot. And this is important. Again, guys, you really need to pay attention to where the sensory deficits are for different nerve injuries, because they will ask you this. They'll give you a case, and the case may be confusing, but if you focus on where the sensory deficit is, it could definitely help you a lot. So you have anterior cutaneous branch, which is this branch. So this is an anterior view of the leg. So if you have an injury to the femoral, you would lose sensation in this area, which is anterior cutaneous branch. If you have femoral nerve damage, this area would lose sensation. You would also have skin deficit, sorry. A skin deficit means sensory deficit on the medial leg and foot, right? And this would be due to a different nerve called the saphenous nerve, which is a continuation of the femoral nerve. So as you go downwards medially, you would have a loss of sensation, and also in the thigh. The obturator nerve, again, similarly, it could be, there's two ways in which it could be damaged. Obviously, the obturator nerve is the one that comes out from the obturator foramen, and the muscle that supplies are the adductors, right? So if you lose the obturator to anything, you could have problems with hip adduction and skin deficit. So as I showed you in this picture, this anterior cutaneous branch of the femoral supplies this area, but you have a very small area in the corner here, which is this, and this area is supplied by the obturator cutaneous branch. So if you have damage to the obturator, its cutaneous branch would not work, and then this area would be damaged, which is like the very, very, very medial area of the thigh. It's a very small area that's otherwise supplied by the femoral, but this small area is just supplied by the obturator. So, how could you damage your obturator? Anterior hip dislocation. So remember the ones for the superior and inferior gluteal were posterior hip dislocation, or radical retroperic prostatectomy. They're never gonna ask you this, but sure. Okay. Injury to sciatic nerve. It's the largest nerve in the body, and it's the main pathology, the main way it gets injured is because if you have inflammation or excessive hypertrophy of the piriformis muscle, which is a muscle in the same region as the gluteus muscles. So the sciatic nerve actually pierces this muscle, so it goes through it, and basically, if it's inflamed, then it would squeeze the sciatic nerve, causing it to become injured, and this is known as piriformis syndrome. Another way the sciatic could be injured is via gluteal injections. So normally let's assume this is your gluteus, okay, right and left. So the main area you would do gluteal injection is the upper outer quadrant, which means this quadrant right here. So you would do the thing somewhere here, because the sciatic nerve, the way it courses from the outside is something like this, right? So you would do the injection in this quadrant, which is the upper because it's upper, and outer because it's outer. Like, so basically, if the injection is given, like for example over here, it would injure the sciatic nerve, and then also could cause sciatic nerve problems. Similar posterior hip dislocation, again, because it's passing in the same area as the superior and inferior gluteal. The typical presentation would be flail foot, and this is different from foot drop, if you guys have heard of that. So in foot drop, you're gonna have inability to difference between flail foot and foot drop is basically in flail foot, you're not able to control your foot at all. It's just a floppy piece of meat. You're gonna have no tone in your foot, and it's gonna look like this. It might look similar to foot drop, but it's not foot drop, because foot drop is only if you ask the patient to plantar flex, they won't be able to do it for you. But in flail foot, the patient's foot is just like it's a piece of floppy. It's a floppy. Yani it's just floppy meat like this. He cannot control it at all, or she cannot control it at all. That's the difference between foot drop and flail foot. Foot drop, you can still have control over your foot. It's just weak and it's dropping. But here you just have no control over it and it's just present like this. You can't move it at all. And where you would see foot drop is in the tibial nerve. Sorry, no, in in common fibular and superficial fibular and deep fibular. You'll see it in a bit. So now we could have the tibial nerve, which is this nerve coming in the back, and it's associated with the tibia. So it could be damaged in the popliteal fossa because that's where it kind of starts. And the muscles involved would be the gastrocnemius and the soleus, which are the calf muscles. And a typical sign would be inability to stand on your toes. And this is really easy to remember because the soleus and the gastrocnemius are kind of responsible for anything when you stand on your toes. Like, you know, when you go to the gym, you do like you when you're curling or like when you're trying to do plyometric exercises, you try and stand on your toes, and you'd see that your calf muscles are being contracted. So you would have this inability if these muscles are injured. So what would you lose? You'd lose plantar flexion. And plantar flexion is when you're trying to when you're doing that, like if this is your foot, right? If you're trying to move it down like this, that's plantar flexion. And if you're trying to move it up, that's dorsiflexion. And the way I like to remember this is plantar is similar to planet. So you're moving your soul towards the planet. So that's plantar flexion. So this would be lost because it's the function of the tibial nerve. You would also have loss of sensation over all the digits. And by digits, I mean your big toe and your other little toes. You have loss of sensation over them. And the reason for this is because the tibial nerve gives you these two cutaneous branches called the lateral plantar nerve and the medial plantar nerve. These are both branches of the tibial nerve, and they supply the digits with sensory supply. So if the tibial nerve is damaged, these distal superficial cutaneous branches will be damaged as well. So you have loss of sensation over the digits, only the digits, only this part. You would not have any loss of sensation over here. Now we have the common fibular nerve, which is also known as the peroneal nerve, but it's more commonly called the common fibular nerve now. And how could this be damaged? If you have a fibular neck fracture, because it's associated with the fibular neck, just like the tibial nerve is associated with the tibia. So a typical sign would be foot drop because you would have lots of dorsiflexion. Dorsiflexion, as I said earlier, is moving your foot upwards. And this is because dorsiflexion is caused by common fibular. You would have an inverted foot because the everter muscles would be lost, and you would have loss of sensation over the dorsum. The entire dorsum would be affected, which means basically all of this, including the area supplied by the deep fibular and superficial fibular, would be lost because the common fibular is the precursor to these nerves. So all of this area, as which you can see is being highlighted by me right now, would be lost if you have common fibular nerve injury. And by the way, the next few nerves, the common fibular, superficial, and deep fibular, a lot of differences, which might not be as glaring, but they're tested in your OSPI and in your MCQ, so you should be aware. So the sensory loss here would be this entire dorsum of the foot. You would have dorsiflexion loss, which causes foot drop, and you would have an inverted foot, which means the foot would be medially rotated, like it would be inwards, basically. And you would have foot drop, which looks like this. So if you have deep fibular nerve injury, you will have foot drop again, because you will see that for superficial fibular, you have a different case, but for deep fibular, you'd have foot drop, and the skin deficit, instead of being over the whole dorsum, as it was for common, it's only going to be over this first web space. This orange thing that you can see here, that's the only place you're going to have a loss of sensation. The rest of the foot is going to be fine. Superficial fibular, you're going to have an inverted foot, but no foot drop. So as you can see, in common fibular, you're going to have both because the function of the common fibular is both through its branches, superficial and deep. But if you have only deep injured, the only thing you're gonna have is foot drop. You're gonna not have any inversion of the foot. Whereas in superficial fibula, you would have inversion of the foot, but no foot drop, because these nerves supply different muscular layers, right? And depending on the loss of function is what you would have. So is the presentation you would have. And in this case, the skin deficit was only the first web space and the rest of the foot was fine. And here, the skin deficit would be everything in the dorsum except the web space. You would still be able to feel the sensations over your first web space if you have superficial fibular injury. But if you have deep fibular injury, you will be able to sense everything on the dorsum except this first web space. And then if you have common fibular, common fibular injury, yeah, then the entire dorsum, including both parts, would be lost. I hope that's clear. We're almost done with this lecture too, and the time is 1:34. Okay. So dermatomes, there's three that you must know. I mean, there's a lot of dermatomes, but you're supposed to know these three because they're important: L4, L5, and S1. So L4, as you can see, this is the anterior view. It's this medial side of the limb, below the knee. Okay, so below the knee, medial side. So the medial leg, basically, plus the big toe is L4. L5 is anterolateral leg. It kind of curves into the back here as well. This is a posterior view. And toes 2 and 4, right? And then S1 is lateral border of the foot and the little toe, which basically means the last toe. And then, as you can see, the lateral border of the foot this way. So L4, L5, S1, an easy way to remember it would be it's going this way. Okay, so L4 is medial, L5 is in the center, anterolateral, plus 2 to 4. S1 is the most lateral, and it's only the pinky. L4 is only the big toe. And then I think you have one last thing, which is the reflexes. You will do this again in neuro, but the reflexes you are supposed to focus on are the knee reflex and the ankle reflex. The knee reflex tests these levels of the spinal cord, L2 to L4, and the muscles which would cause the knee reflex are the quadriceps. And for ankle reflex, you're going to have these two spinal levels, S1 to S2, and the muscle involved in the ankle reflex is the gastrocnemius. So again, the muscle really doesn't have like usually when you're testing for reflexes, you're assuming you're trying to look for like a neural problem. So if you find some problem in the reflex, it means that there's a problem at this spinal level or at this spinal level. But you don't need to know that for now. Just remember L2 to L4 is knee, S1 to S2 is ankle. You're testing the gastrocnemius and the quadriceps are the ones that cause the reflexes. Okay, so we're done with lower limb and we're going to begin clinical anatomy now, which is the last part of this PAL session and the last clinical lecture for this block. You're going to have bursae around the shoulder. So what are bursae? They're small fluid-filled sacs that act as cushions and lubricating structures between the bones. So basically, they reduce the friction between the tendons, ligaments, and bones so that everything moves around smoothly. They're basically like you know how when you get something from like you order something, you have packing peanuts to kind of like reduce the friction between the thing that you ordered in the box. It's similar to that. So you're gonna have many kinds of bursae, but the ones that are on the shoulder, the main ones are the subacromial, which is this one over here, and it's a subacromial because it's under the acromial process. The subdeltoid one is the massive one, which is right under the deltoid. This subscapularis is the one which is present over here. Subscapularis, it's not very visible, but it's over here under the scapula. And its function is that it separates the subscapularis muscle tendon from the shoulder joint to prevent any friction. And then you have the subcoracoid bursa, which is below the coracoid process here. So all of these perform the function of reducing friction. So bursitis is a pathology of the bursa in which they're inflamed. Usually the bursa are not inflamed due to a primary condition, which means something is causing them to be inflamed. They're not inflamed by themselves. And this something is usually irritation, which could be in the form of supraspinatus tendon swelling. You will learn that out of the rotator cuff muscles, or basically in general shoulder muscles, the most annoying one is the supraspinatus because it's always the one that seems to have a problem. Um, and this is because it's always dragging around. We'll learn the cause why it's always we'll learn why it's usually the culprit in most cases, but the supraspinatus could be swelling, and it will cause irritation, and this irritation will be transferred to the bursa and cause bursitis. So, or you could have bicep long head degradation and swelling. As you know, the bicep has two heads, the long head and the short head. So if the long head degrades or swells, you could have bursitis. So basically, these conditions are the primary condition, and then the secondary condition could be bursitis because of them. So the clinical features for bursitis are deep-seated and aching pain, uh, holding the arm in slight abduction, okay, and tenderness present of the edge of the acromion. So the deep-seated aching pain is pretty self-explanatory. It's just like really bad pain in that area of the shoulder. You'll hold the arm in slight abduction because the rotator cuff muscles are affected, okay? And you want to basically relieve them, which is why you hold the arm in slight abduction. And the tenderness present of the edge of the acromion process is again like it's a marker for inflammation. If something is inflamed, it's going to be tender, right? That's pretty common sense. Now you're going to have impingement syndrome, which is basically it's a group of clinical features. And what happens in impingement syndrome is the gap between the acromion process and the humerus, which is this gap over here, is going to be narrowed down. So all the structures that pass through this are going to be affected. And on X-ray, we can see it as characteristic scarring. So as you can see, this white matter is basically indicating the scar that is caused due to impingement syndrome. Now, what exactly is affected in impingement syndrome? Well, it can be anything that's in this area. And the most common thing that's affected is the tendon of supraspinatus. And as I said earlier, supraspinatus is the one that's usually affected in the rotator cuff muscles. And the reason is this. It's sitting in between these two structures. And when they compress it, it causes damage. So why could you have impingement syndrome? Because it's not normal to have it. The first thing is arthritis. If you have arthritis, you're gonna have this bone, these bones coming closer together, and that would cause friction with the supraspinatus. You could have unusual growth of the acromion. So as I said, the acromion process could grow and compress. You could have bursitis. Okay, the bursitis. Remember, you have a subacromial bursa. So the subacromial bursa could be inflamed and it would compress all of the structures that are present within this narrow groove. You could have bicipital tendinitis. Again, as I said, if the bicep is degraded or inflamed, it could also cause this area to be very narrow, and then the supraspinatus tendon would be affected. And then previous bony injuries, which would cause calcification and like, healing mechanisms that would compress the supraspinatus tendon. So you would have this kind of characteristic X-ray. And then painful arc syndrome is a subtype of the impingement syndrome. And it's when you have a painful rotation, painful abduction between 40 degrees and 120 degrees. And the reason for this is because you could have bursitis or tendinitis of the rotator cuff muscles. So if it's bursitis, then the bursa involved are the subacromial bursa, as I said earlier, or the subdeltoid, because as I said, the deltoid is responsible for abduction. So if the abduction problem, think deltoid, and if you're thinking deltoid, then the bursa is obviously subdeltoid. And then the muscle tendon, as I said, always the culprit supraspinatus muscle. It's responsible for abduction as well. It assists the deltoid. So if you have painful abduction, it's called painful arc syndrome, and the reasons could be tendinitis or bursitis. So now the rotator cuff muscles are the sits muscles. I'm sure you know them all by heart. If you don't, good luck. The most commonly injured one is supraspinatus. And the reason for this is it glides over the head of the humerus and it's stuck between the acromion process and the top of the humerus in this narrow space. So the common sign is difficulty abducting, as I said earlier, painful abduction. And so basically, um, if you remember your anatomy lecture, supraspinatus is the one that's responsible for initiating abduction before the deltoid takes over. So if you have difficulty abducting, especially in the first few degrees, which is 0 to 15 degrees, then that certainly points towards supraspinatus, because after that, the deltoid takes over and does the rest of the range of motion. So the patients might use a trick where they swing their arm outwards using their momentum, and then the deltoid takes over, so they don't have to use their supraspinatus. So yeah, make sure you take a note of that. And then the reasons why it could be injured, it could be a sprain because of an injury or overuse. It could be a partial tear or a complete tear of the tendon, calcification of the tendon due to genetic diseases or just old age, tendinitis, again, due to an injury, due to overuse, or degeneration, again, because of injury, overuse, atrophy, because of degeneration, anything. Then we have something called frozen shoulder, which is also known as adhesive capsulitis. The capsule in question here is the capsule that surrounds the glenohumeral joint. And basically, the glenohumeral joint may become inflamed, and usually this happens due to old age, and it's more common in women. So the reason is just old age. There is no pathological reason. So when you have this old age, the glenohumeral joint may become inflamed, and the capsule may become inflamed with it, and they start adhering to one another, the different parts. So basically, it kind of it traps the joint and doesn't allow a free range of motion. So you'd have difficulty abducting again at shoulder joints. But it would be different from supraspinatus injury because in supraspinatus you have difficulty abducting the initial few 0 degrees to 15 degrees, whereas here is difficulty abducting at anything. So we're almost done with the lecture now. I think we've made good time. So the most commonly dislocated one is for shoulders. I'm sure you've already done this, but this is just a review. It's the most commonly dislocated joint because it has a large head, the humeral head, and the small fossa, which is the glenoid fossa, is really small. It's unproportional, and that's why the shoulder dislocations are very common. And most of the dislocations are anterior inferior, and in this case, you would have damage of the axillary nerve, if you remember from earlier in the lecture. And this is because the inferior region is the only one that's not reinforced by the other some parts, as you will see. Superior dislocation is extremely uncommon due to coracoacromial ligament. I'm sorry for not adding a picture. I really wanted to, but you can search it up right now. Coracoacromial ligament is right above. It joins the coracoid process and the acromion, and it does not allow superior dislocation of the humerus. Again, posterior dislocation is not possible due to the sits muscles, which are the rotator cuff muscles, and the thick capsule. So the only place that's left is the inferior. So it goes inferior and then goes anterior. Because once it's gone inferior, there's nothing holding it back. But then when you have shoulder dislocation, a very common presentation is rounding of the shoulder, which is because of the axillary nerve damage and the loss of contour because because the deltoid will be affected, and basically the loss of the capsule, the loss of this joint causes rounding, and then you have adduction of the arm. Adduction meaning it going towards the midline, and the reason for this is because now that the humeral head is free, it's no longer connected to the capsule, the pec major and the subscapularis muscle will pull on it, causing it to become adducted towards the body because it's no longer supported by the other muscles, such as the rotator cuff muscles. It's free on its own. The pec major is going to pull it towards itself. So the pulse points in the upper limb, very easy. The first one, which is the most common, is the mid-arm, slightly above the cubital fossa, is where you palpate the brachial artery. The mid-arm, which is this one, is another one. Sorry, where is it? Okay, this one. Not very common and not really ever used. The radial pulse is the distal forearm on the radial side. The ulnar pulse is distal forearm on the ulnar side. And under axilla is the axial pulse, right? Again, axial pulse not really taken. Ulnar pulse not really taken. Radial pulse is taken sometimes, or like a lot of times actually. So the radial pulse and the brachial pulse are very important. And then I think this is the last one. Okay, so the glenoid labrum tear and separated shoulder. So as you guys remember, you have a glenoid labrum, which surrounds which surrounds the joint, the shoulder joint, and it could tear. It could tear because of trauma. It could tear spontaneously. Uh, Many reasons. And this would cause dislocation of the shoulder joint because, as I told you, the shoulder joint is a very weird joint because of how unproportional it is. So if its protective mechanisms are broken, such as the glenoid labrum is broken, then it would cause dislocation of the shoulder. And this would be corrected by repairing the labrum with sutures and metal plates to make it more sturdy. A separated shoulder is not a dislocated shoulder, so please don't make this mistake. A separated shoulder is when you have a acromioclavicular joint injury. The acromioclavicular joint is the joint between the acromion process and the clavicle. It's basically the one that forms the glenoid fossa. It's the one that forms the fossa where the humeral head can sit. So if this is separated, then obviously the whole joint's integrity is going to be messed up because its fossa, where it was supposed to be sitting comfortably, is no longer present because it's been injured. Um, so this could be due to trauma, most common reason for a separated shoulder. Again, it's not the same as a dislocation. And one more thing that you should remember, we already covered it, but anterior inferior dislocation causes the axillary nerve damage. It's a very, very high yield question. Okay, so now we are done. I hope you guys found it beneficial. I hope you guys appreciate the fact that it took less than an hour, I think. I'm not sure. But I tried to make it as quick as I could because I know you guys have so much more to do. I hope this was a good review. I did not skip out on anything. So hopefully everything that you will be tested on is included in this PAL session. And I'm praying that all of you do well. And inshallah, please pray for me as well. And now we're officially done. So can you please scan this? It'll take you like 30 seconds to fill it out, and then you can um, maybe do something productive, um, such as study. Thank you guys. You can text me if you need any help. I'm always here. MSK is my favorite block, and yeah, that's it. I'm here to help you always. Um, I hope you do well in your exam, and you're almost done with first year, and the time's gonna fly, inshallah. Good luck on your exam. That's it. Thank you so much.